the US, that clearly shows that you can improve patient experience, you can improve levels of utilisation, you can make significant savings, and you can improve the quality of care. So, if it's that good, why aren't we doing more of it? There are a number of reasons. The first is the cost of the equipment. It's very high. The unit cost of the kit that people are buying in the UK is very high. It means that rather than the predicted 3 million people, which we believe could benefit from telehealth, the cost-benefit analysis means currently only something like 300,000, a tenth of that number, would benefit. So we've got to drive costs down to make it more commercially viable, to spread to a much broader number of patients. There's a real lack of interoperability. Those thousands of organisations I mentioned earlier that are individual businesses or individual organisations are all doing their own thing, procuring information, procuring systems from different providers. They're not interoperable, they don't talk to each other, they're isolated, they work in very, very small parochial communities. There's a lack of poor quality standards, something we're trying to address, but again it is a real issue. There's a lack of appropriate training for the workforce. One of the key issues with telehealth and telecare is that it transforms the role of workforce. It transforms where they deliver care and how they deliver care, and that's incredibly difficult, particularly getting clinical support from representative organisations, Royal Colleges and the BMA. But mainly, it's about a lack of evaluated evidence on the clinical benefits that telecare brings. So what are we doing about it? Well, we think we've got the largest randomised control trial in the world. 6,000 patients, including our controls, in 230 general practices with over 9,000 home visits. The results of that are due towards the middle of next year. Early indications show, as I guess you would imagine, that people adapt to the equipment quickly, they feel supported, they like it, patient experience improves. But the results are promising as well. They're showing reduced levels of utilisation and attendances at hospital. They're showing that we can save money. But it's also showing, importantly, it's not the technology itself that is the solution. It's the services that you wrap around the technology that provides the real benefit. So just buying the kit, installing it in someone's home isn't going to give you the clinical or the financial benefit that you want. You have to retrain staff. You have to have support services around that to make the package work. Also the issue I mentioned about scale. And having said that the centre is no longer going to push ideas out to the NHS, the model we're probably looking at is one that's nationally specified and possibly nationally procured, locally commissioned. The reason for that is that individually those component parts of the NHS just don't have the scale to negotiate anything like an efficient or an effective deal with some of the big healthcare manufacturers. The last thing I want to talk about is NHS Global, which is a single portal for partners to access the NHS, a problem that's existed for some time. We speak to a number of people overseas who say they really struggle to understand who to talk to in the NHS if they want to partner or if they want to develop partnerships with them. An idea behind NHS Global stemmed from those accusations I mentioned earlier that came from North America a couple of years ago during the last presidential campaign, where the NHS was portrayed as a third-rate healthcare system. And that was at a time when 2/3 of the globe were taking learning direct from the NHS, including the US, which was really galling at the time. But it struck the then Prime Minister and the Minister for Health into action, and they decided they wanted to create an organisation that would do three things. The first was build and grow reputation for the NHS overseas. The second was compete in the international healthcare market and exploit the commercial value of the NHS's own IP, something individually some hospitals do. So you're probably all familiar with the Royal Marsden, Great Ormond Street, Imperial, Moorfields Eye Hospital. They've got a good brand overseas. They make lots of money overseas. They do lots of good charitable work overseas, but it's isolated. It's done on nothing like a systematic scale right across the NHS. And this model is designed to try and help that. And one of the problems that we faced was the amount of income that the NHS can generate from private patient activity is capped. Something like 2% of income and no more. So there's no real incentive for them to partner overseas. There was no real incentive for them to do much private work. There was no real incentive for them to commercially exploit their IP. Now, importantly, that's going to change. Government, new set of views, they've signalled very, very clearly that they want to scrap that private patient cap. Now, when that goes, you're going to have a lot of very influential, very powerful, very big foundation trust, hospital trusts, that are going to look to start building partnerships overseas. They're going to start to look to compete internationally for tradable services, healthcare services, inbound and outbound, and also start to promote much more effectively, exploit the commercial value of their own IP. And lastly, NHS Global was also designed to strengthen the philanthropic work that we do with low to middle income health economies right across the globe. The idea is relatively new. New administrations made that commitment about the private patient cap, which is relatively new. The case of watch this space, because quite quickly those FTs, once the private patient cap goes, will start to work with UKTI and want to start working with people like yourselves and many others right across the globe to try and develop new partnerships overseas. Just very quickly, one thing I want to mention as well, because I get shot if I don't, Healthcare Innovation Expo, which is an event very similar to this one that we put on in the UK. It's the largest event of its type in Europe. There's 10,000 chief executive officers and key decision makers will attend. It brings together the public, the private, the academic, research and voluntary sectors to talk about healthcare, innovation in healthcare, partnerships in healthcare. There's over 250 public and private sector organisations exhibiting. It's the 9th and 10th of March next year. There's a website which I'd encourage you all to go to, have a look, see what you think of it. If you'd like to get involved, let me know. If you'd like to come along just to attend, that would be great. If you'd like to come along and exhibit, that would be great. If you'd like to come along, get involved in some of the seminar programmes that we've got, that would be great. This year, unlike last year, there will be a specific zone about international activity and international healthcare systems. So I do urge you to go and have a look at that website. That's all I wanted to say. Thank you very much.